Today, I'm going to talk about how to manage intraoperative challenges. I would like to emphasize you again, the uveitis is not a single disease, but it's a group of diseases that share common characteristics, which is intraocular inflammation, which is the same thing of uveitis cataract. In the uveitis cataract, you can face with many challenges. The cornea can have very low endothelial cell count, cornea can be edema, you can have poor view due to band keratopathy. Anterior chamber can be very shallow with peripheral anterior synechial and maybe iliacordial adhesion. Iris and pupil as the are most concerned for the surgeon. The pupil can be very small, myotic pupil like the picture you see on the right. Posterior synechial can happen. Irisotrophy. Irisopathy is another challenge. And you can have pupillary membrane and bleeding from abnormal fragile iris vessel during the surgery. The lens can be varied. You can have very soft, you can have very hard, you can have the mature cataract in uveitis cases. Zonular support can be compromised. You can have phacodonesis, and sometimes you not know until you go into the surgery because the lens is held by the posterior synechial. Anterior capsular fibrosis can compromise the capsular access and can cause the problem during the surgery. To manage the small pupil, first, surgeon might need to evaluate the cause of small pupil and correct it in the right way. Posterior synechial, we can do the synechial with variant technique that I'm going to show you today. Pupillary membrane can be removed. For the iris, we can do stashing, dilating with the many devices that are available in the market right now. Irisotrophy can cause small pupil as well, and post-acute glaucoma attack that can cause the small pupil too. Bleeding is another challenge, and we have the way to control it. Increase AC pressure, anterior chamber pressure. You can increase the IOP using your phaco machine, like increase some button height, or in the Centurion, you can just easier go up with the IOP to whatever you design. OVD choices is also important. For my preference, I prefer high molecular weight dispersive OVD because that OVD can push the lens iris diaphragm back, increase the pressure, hard to leak out from the eye, and can stop the bleeding. Consider smaller wound size that can limit bleeding, increase the IOP and limit bleeding too. If you have the bleeding from the iris on the vessel, intraocular cautery is another way to stop it. This is the video show how to do the synechial with the blunt tip cannula and high molecular weight dispersive OVD. You can go with another paracentesis to approach the T60 degree of the synechial and put the viscoelastic end to dilate the pupil. Another way is you use the instrument like Lester lens, two instruments to stash the pupil 90 degrees apart, and after this, probably you do the visco dilatation, put the viscoelastic into the anterior chamber, and sometimes that should be enough to open the pupil to perform the surgery like this case that video show. Another way is we can use this intraocular scissor to cut the iris sphincter and use the instrument to dilating the pupil again with 90 degrees apart. We rarely use this technique now because it's going to cause bleeding and it's going to cause more trauma with the pupil. When you have the interpupillary membrane, you can just easily remove with the forceps, and after that you can either do stashing or viscodilatation to dilate the pupil. But sometimes when you have the thick membrane at the border, please be careful about the bleeding. Like shown in this case have the very thick interpupillary membrane, I use the forceps to remove the interpupillary membrane first and avoid to use the cystosome, because the cystosome can cause the damage to underneath anterior capsule and cause anterior capsule compromise, like you see on the right side of the skin with the intraoperative OCT. The membrane is very thick, and sometimes when you remove the membrane that is very thick, you need to emphasize that too much stitching can be harmful. It's not cause only bleeding from the iris and from the pupillary margin, but sometimes it can even cause the iridodylisis and cause a lot of trauma and bleeding from the anterior chamber angle. And this is after we remove the membrane, we go to do the real capsulorhexis. I use the cystosome to open it up, and you see on the OCT on the right hand side, and we do the real capsulorhexis with the forceps, capsulorhexis forceps. Again, in this kind of cases, Lex is a little bit more preferred because you can more control to open the capsulorhexis, because the membrane can be thick and can be different in the many parts of the anterior capsule. Another device that's very helpful is the iris hook. You can use iris hook to open the pupil up. 3 or 4 iris hook is very helpful. A little tip that helps us is when you put the hook in, don't put the hook right away. When you put the first or the second hook in, you put it in all together, and you slightly adjust the hook. That way, it's gonna be much easier to put the second, third, or fourth hook in and limit the trauma to the pupillary margin. Another device is the Mayukin ring or another dilating device. This is show how to put the Mayukin ring in. The nice thing about the Mayukin ring is when you put it in, it's dilating the pupil, and you also use the second instrument to rotate the ring around the pupil. Poor zonular support is another challenge. In the case that have poor zonular support, forceps is also preferred than cystosome because it's going to be easy control to open the tear. Capsular tension ring can be held, and we have so many styles of the capsular tension ring. Iris hook can also helpful during the surgery, not just open the pupil up, but also can hook the anterior capsule of the lens to hold the lens in place. Luckily, right now, we have the capsular hook that support through the equator of the lens, and that gonna more stabilized than the iris hook to support the lens that have phacodonesis during the surgery. Even the case that don't have much phacodonesis, but in uveitis, it's a good idea to put the CTR in, because post-operative inflammation can cause another complication like the post-operative capsular fibrosis, like you see in the right hand side of the skin. This video will show how to use the iris hook, move from the iris to hook the anterior capsule in case that have the poor zonular support. You can use 1 hook, 2 hooks, 3 or even 4 hooks to hook the anterior capsule, and after that you remove the remaining lens in the eye and avoid to touch the area that you hook with the capsular hook. Remember, the capsular hook, the iris hook is hooked only in the anterior part of the lens. The posterior capsule can come to the phaco tip and cause the damage to the posterior capsule. This video shows to you the second instrument to prevent the posterior capsule come to the phaco tip. After this, you may need to use the viscoelastic to opening the hook, the back, and put the CTR in, and put the lens in the back. Lens removal and cortical removal in the small pupil is also another challenges. remove all lens material is a key to prevent postoperative inflammation. You might need to use the second instrument to expose the residual contact in the small pupil cases. Bimanual technique may be helpful. Bimanual IA or bimanual limbal anterior vitrectomy with cutter-off function is also very helpful. Some small contact in the uveitis eye can cause month or year inflammation, so it's very important to remove it all. This video shows how to use the second instrument to expose the remaining contact and remove all the contact from the subincision area. In summary, uveitis is not a single disease. Know your patients, not only the eye. Choose the proper equipment for the different kind of uveitis cataract. Why we choose OVD? Right, high molecular weight dispersive OVD. And wisely adapt your phaco parameter for the different cases of uveitis cataract. Proper techniques for the different cases, and always have backup plan in case of something happen intraoperatively.